So this is 401A, the traditional model. It speaks to a person with mental illness who can be expected within the near future to hurt themselves, and has acted in a way that supports that. And we have some interesting cases interpreting that now. Note that 401A doesn't have the language dangerousness or threat of immediate harm. It's not in there anymore. And we have a couple of Court of Appeals decisions that have interpreted this section and have said that the act that supports the order under 401A doesn't have to be contemporaneous with that hospitalization, but it can be an act from years earlier, so long as it substantially supports the expectation. So we had another panel of Court of Appeals that said the act from 2 years ago could be the act that would support a finding that the person needed treatment. And they cite the doctor's statement that past history is more predictive of future behavior than current statements. 401C has undergone major change. And basically, we're looking for someone who has a mental illness, their judgment's impaired, they don't understand the need for treatment, and that causes them not to participate in treatment that's necessary to prevent a relapse or harmful deterioration, and that presents a substantial risk of significant physical or mental harm to the individual or others. The near future is not included. So in the Spalding case, the Court of Appeals held that the testimony from a doctor that untreated schizophrenia increased the risk of dementia, drug abuse, suicide, and further decompensation, including delusions and paranoia, was sufficient to order involuntary treatment. What's interesting about that case is the doctor testified that the respondent was not at risk of harm at the hearing, but was at risk of harm due to his lack of insight and history of decompensation. In fact, the doctor testified that he could be expected, due to his lack of insight, to stop taking his medicine in 3 to 6 months and decompensate and be subject to all the risks inherent in that.